The short answer is that we don't really know how clozapine works. Clozapine has been around for many decades, but and it's very unique. The clinical data, clinical studies show us that it's very effective when other antipsychotics have failed. So for people who fail to improve on the medications we would traditionally use, when we use clozapine, we have a greater chance of success compared to other drugs.
Somebody get this guy some help!
So today on the podcast, I have Jose Rubio, an MD and board certified psychiatrist, researcher, investigator that specializes in SMI or severe mental illness, typically schizophrenia, bipolar 1 disorder, maybe some traumatic brain injury patients. He obtained his MD from the University of Valencia in Spain and completed a psychiatric residency at Zucker Hillside Hospital, where he was chief resident for research. His research has specialized in relapse and treatment resistance in schizophrenia, and he has worked extensively with John Kane, a psychiatrist who was tasked by the FDA to wean a few dozen patients off of clozapine in the 1970s due to what I understand is several Scandinavian deaths from one of its more rare side effects affecting immune system function. Um, Dr. Kane found that many of these patients' symptoms reemerged or significantly worsened coming off of the drug and became a major advocate, paving the way for clozapine's eventual 1989 FDA approval for treatment resistant schizophrenia. Independently, Dr. Rubio has received several awards, including the Excellence in Research Award from the Feinstein Institutes and a NIH Career Development Award. Has additionally been recognized by awards from major scientific organizations such as the APA or American Psychiatric Association, the Schizophrenia International Research Society, and the American College of Neuropsychopharmacology. He currently works, I believe, as an assistant professor at Zucker School of Medicine at Hofstra, and clinically, you see patients at Northwell Health. Does that
That's correct.
summarize? Is that
That
a good
summarizes
introduction?
it. Yes, thank you very much for the invitation, and yes, that introduction is accurate.
Okay, so yeah, Dr. Rubio, thanks so much for appearing on the podcast. Here at Renegade Psych, I try to appreciate the nuance involved in complex psychiatric and medical decisions, educate listeners on the lesser known aspects of the field, and provide an outlet for what is truly evidence based medicine versus what is more marketing based medicine. It only made sense to have you on to discuss how we treat resistant schizophrenia, how we should treat it, and identify some areas where we're falling short in our efforts. I'm here to get more of your thoughts about clozapine, the underutilized gold standard for treatment resistant schizophrenia, as well as your professional thoughts and opinions on schizophrenia. But before we get there, first, I want to know a little bit more about Jose Rubio, the person. So I want to start off with a few kind of rapid fire questions, if that's all right.
Of course.
So first, where were you born and raised?
So I was born in Granada, which is in Andalusia in Spain, but I was raised in Valencia, also in Spain. That's a city in the Mediterranean, and I trained there as a doctor, although I studied 2 years abroad. So I lived in the Czech Republic for another year, and I spent another year in Granada again. And then I came to the US when I was 25 because I wanted to do residency here. I was attracted by the quality of research. So I came to New York in 2010 and I worked as a research assistant at Columbia, and then I started residency here, and that's where I've remained ever since at Zucker Hillside Hospital.
And there is something that brought us together because I've actually been to Granada
Oh,
before. On my one trip out of the country, my sister in law was living in Madrid for 2 years, and we took a trip to Granada while we were there. Um, Now, is Granada south of Madrid? Is it
yes.
in the mountains? or
Yes, it's south, and yes, it's in a mountainous area, so it has a big ski resort and the
and I've
highest
been
peak
there.
highest peak in the Iberian Peninsula.
Um, just a very quick aside. The first time I ever went skiing was in Granada, and my now wife and her sister in law were they were not advanced, but they weren't novices either. And we went up into the mountains, and they said, "Oh yeah, just French fry, just pizza," and they didn't give me a very good tutorial on how to ski, and I I wiped out. I lost my skis, my poles, probably 25 to 30 times that day. Luckily didn't hurt myself. I almost did towards the end of the day, started getting a little bit of my feet under me, and I almost ran into a 5-year-old girl, and her dad, speaking Spanish, was not very pleased with me, and I didn't know exactly how to apologize. I was just glad that I didn't actually run into her and wiped out instead. But it was funny. I got to the bottom of the mountain last run of the day, and sometimes you see a group of people and you may think, I think they might be talking about me, or maybe I'm just paranoid. And they're laughing. And then at the end, one guy came over to me who spoke English, and he said, "Hey, I just want to let you know, if you hang around, I would love to offer you a free training on how to ski." So they definitely were talking about me, but it's interesting that that's roundabouts where you grew up.
Yeah,
So
yeah.
as an adolescent, as a kid, what did you want to be when you grew up?
I didn't know. I think I was not very. I didn't have a very clear idea. I think it was more. I was interested in understanding how we work as humans from probably a rather concrete perspective of biology. So I was interested in human biology, and then I decided to do medicine because, you know, um, I that was a way of understanding human physiology from a very concrete level, and then obviously took a different dimension once I was able to interact with people that were ill and to uh, see that I could be very helpful in trying to make their lives better. So kind of like had those two dimensions, that of like helping others, which can be very satisfactory, and also to under the the intellectual component of trying to understand better human biology and who we are as entities.
Yeah, absolutely. I think that you're stating some of the what I would consider to be the best qualities of a good psychiatrist. Primarily, that a good psychiatrist is curious, because there there's a lot of unknowns in medicine, but there are a lot of unknowns in psychiatry and what drives our illnesses and how best to treat them. Um, so I was saying, you told me a little bit about your kind of professional journey, your path, but tell me a little bit about one or two of some of your greatest professional influences.
Well, I mean, I could tell you two. One of them probably would be my first, the person that was teaching us our first psychiatry courses. His name is Julio San Juan. He's a now he's retired now, but he was a full professor at Universidad de Valencia, and he was really good at making people feel curious about stuff. And I was coming in already very motivated to to understand, to learn about psychology, psychiatry. But he really made a great job at feeding that curiosity. So he certainly would be the first person I would highlight. He, probably he had a strong influence on me becoming a psychiatrist. And then obviously the second person would be John Kane. He's been my mentor and friend for a few years already. I started working with him when I was a resident, and I have continued to work with him ever since. he's been, uh, very. Uh, he's really an example for me in terms of work ethic and intellectual curiosity, and as a whole person, not just as a doctor. To me, he's an example. So those two are. I mean, if I have to cite two, those would be the two I would cite.
Yeah, that's an incredible opportunity to be able to work with him and learn from him as a resident. Certainly. So, what about when you need to get away from work? You need to get out of all of this and kind of reset mentally, emotionally, spiritually. What do you do?
I babysit.
Now, my
uh,
wife says it's not babysitting if it's your own kids.
okay. No, I mean, well, certainly that's a very important part of it. But I mean, the things that I enjoy reading. I enjoy traveling and eating new stuff and discovering new things. So I think that's what I would say. But certainly, being around my children is really what takes most time.
Absolutely, I can relate to that. I got two, not quite under two anymore, but very close to it. So
Mhm.
takes up a lot of time outside of any work that I do.
Yeah.
Before we go any further, I have to ask: do you receive any pharmaceutical funding? Do you have any other financial disclosures?
Yes, yes, I do. I consult for some companies for different questions related to the management of schizophrenia. I mean, if I have to list what I have done for drug companies, I've done uh, ad board for Bristol Myers Squibb. I have done talks on disease management, not promotional talks, but talks on disease management for schizophrenia for Teva, um, and also Janssen. Also, I received royalties from Up to Date because I was one of the authors of the treatment resistant chapter, and also I've received. I mean, I do CME, so I get paid for that. So I've done that for couple companies, but not drug companies, but CME companies.
Okay. Do you feel like any of those associations affect your ability to be independent in your scientific discourse?
I I don't think that they play a strong effect, especially when it comes to clozapine, because whatever they do is so unrelated to clozapine that I don't think that there's any way in which that is influencing me. Of course, you have to trust me, and but I really don't think that there's any effect. I mean, if anything, they should be funding this research. I wish that I had some conflicts, but one of the problems is that no one is funding this, and as a result, there's not much development in terms of new drugs for treatment resistance.
And clozapine has been out since the late 1950s, so it is certainly generic and probably, and you'd have to back me up on this, is not very expensive for patients in terms of the drug itself.
No, it's. I don't think so. I mean, obviously, all of these things depend on how insurances negotiate prices, but generally speaking, no, it's not a drug. I mean, it's generic, and cost is not a major issue.
Yeah.
Generally speaking,
Okay. Um, and then lastly, for the rapid fire questions, an absolutely loaded question. How would you describe what schizophrenia is to an alien who had never heard of it or seen it?
I would describe it as a mental disorder that affects three major spheres in humans. If this is talking to an alien, so one would be positive symptoms, which is related to, which is essentially psychosis. So, meaning this would be a presence of perceptions that are not triggered by any stimuli, or also some thoughts that are believed that most people would think are very bizarre, or also disorganized speech or behavior. There would also be another dimension of this illness, which would be characterized by negative symptoms, things that should be there but are not there, things like lack of the ability to express emotions or the uh, drive to do things, motivation. And then there would be a third component that would be characterized by some cognitive symptoms. So ability to do abstract reasoning, ability to recall short-term memories, etc. So those would be the three dimensions that this illness is characterized by. And obviously, downstream there are many complications from this. It typically emerges in adolescence or early adulthood, so it affects the ability to develop after that point. Sometimes there are subtle things that we can see before the symptoms emerge. So certainly it has a developmental um, component to it, which may affect many conditions of many aspects of our interaction with the world. So it may affect our or for the people that suffer this condition, it affects their ability to develop social relationships, to the ability to work, the ability to develop a profession, etc., which ultimately may have implications on the financial situation, which is going to feedback, into some of this other risk factors like living in an environment that is less than optimal, which can make things even a little bit worse. So that's in a nutshell the way I would describe it.
Yeah, and I would just add to that for the listeners that typical progression is negative symptoms in late adolescence, early adulthood, typically followed in the next few months, probably closer to years, with positive symptoms or the psychosis that is a lot more obvious and apparent to somebody in the general public when somebody is having under the influence of delusions or auditory hallucinations. I actually practice in an area of the country now. Our entire country is under a major drug epidemic right now. Methamphetamine in particular, I see a lot of misdiagnosis of methamphetamine or chronic meth psychosis as schizophrenia, and while they do have the some of the more typical positive symptoms with persecutory delusion or feeling like they're being followed or monitored, there isn't the typical progression of negative symptoms, and it appears to be a unique condition. Though I think that there are probably some overlap of people who either develop the symptoms of psychosis using meth. Maybe they had a genetic predisposition to it, but still that it's something kind of unique from actual what I understand to be biologic or genetically based schizophrenia. Um, I reached out to you because I saw you pushing for more practitioners to utilize clozapine. Clozapine
Mhm.
is a unique antipsychotic in that it is considered the most effective, but it differs from other antipsychotics pharmacologically with only weak D2 or dopamine receptor antagonism, specific type of dopamine receptor antagonism being blocking effect, which is the most often practiced way of managing the positive symptoms of psychosis, like, as you mentioned, delusions or typically auditory hallucinations in schizophrenia. It is considered the gold standard for treatment resistant schizophrenia, and along with lithium, are the only medication treatments that I'm aware of that have very solid long term evidence that they reduce the patient's risk of suicide, which is a huge risk factor and cause of death in schizophrenia. Yet it still remains widely underutilized in psychiatry. Can you generally explain how clozapine is pharmacologically unique compared to other antipsychotics and what it might tell us being the most effective about the underlying disease of schizophrenia?
The short answer is that we don't really know how clozapine works. Clozapine has been around for many decades, but and it's very unique. The clinical data, clinical studies show us that it's very effective when other antipsychotics have failed. So for people who fail to improve on the medications we would traditionally use, when we use clozapine, we have a greater chance of success compared to other drugs. So we see that it clinically is very unique from the perspective of the biology. There are some things that it does that are unusual compared to other antipsychotics. As you mentioned, the weak dopaminergic agonism. It may also have some muscarinic agonism, which is becoming relevant now that we are understanding that that could also be a very effective mechanism to reduce positive symptoms, but also potentially improve cognition and negative symptoms. So certainly biologically it's a different agent, but we don't understand how it works, which is part of the reason why and it's difficult to develop. If you don't understand the mechanism, it's difficult to develop drugs that can address whatever is not working correctly. So that's certainly an area in which I think we need to spend more resources, which is to understand what are these mechanisms of treatment resistance, so that we can develop drugs or strategies. Doesn't need to be a drug that is more effective than what we currently have to address the symptoms.
Yeah, and to go with that, with most antipsychotics, whether they be specifically first generation, but also many of the second generation antipsychotics, what we believe as one of the reasons why we're able to mitigate the positive symptom of psychosis seems to be related to dopamine 2 receptor blockade. But that unfortunately does not just happen in the area of the brain that we want to block dopamine. It happens throughout the brain and likely worsens negative and or cognitive symptoms. So a couple of questions about the procognitive effect, which is so important in schizophrenia treatment. How robust is that effect? What is the kind of latest on, does it improve cognition? Does it stabilize cognition? How does clozapine affect negative and cognitive symptoms in ways that other antipsychotics maybe do not?
Well, I would be careful about the cognition and clozapine. If anything, I don't think clozapine is great for management of negative or cognitive symptoms. Clozapine is highly anticholinergic, and because it's so anticholinergic, it results in, if anything, well, there are a lot of side effects that come with it that peripherally could present with not dry mouth in the case of clozapine, but could present with constipation, for instance. But uh, in the brain, it can worsen cognition because it's so highly anticholinergic. So I don't think that I would use this drug for people that are struggling with cognition or with negative symptoms. I would for sure use it for people who are presenting with residual psychosis despite two failed trials with an antipsychotic, meaning that they've tried two antipsychotic drugs for sufficient time, meaning at least 6 weeks if it's in an oral. If it's in a long-acting injectable, should be about 4 months, and for sufficient dose, that would be in 600 milligram equivalents of chlorpromazine. So, if that condition is met and you still have residual symptoms, residual psychosis, I think clozapine is a good idea. If it's not so much a problem of residual psychosis, but more a problem of negative symptoms or cognition, I'm not sure I would use clozapine.
Where does, because in my training, it always seemed to be a push and pull with a possible procognitive effect. Do you know where that originally came from, research wise, or where that maybe debate originated?
I'm actually not sure. I'm not so sure about that. I'm not that familiar with that. So yeah, no, I don't know.
Do you think that it affects cognition less than other first, second generation antipsychotics?
Well, it it's a complicated picture, right? Because it's not that cognitive symptoms appear in a vacuum. Cognitive symptoms appear in the context of positive symptoms and negative symptoms, right? So there might be, you could theorize that because it addresses positive symptoms very well, it can help with some indirectly with some cognitive symptoms that present whenever you're experiencing uh, very severe hallucinations or thought disorder, etc. But I think that mechanistically, we don't really know how it works, but we know it's highly anticholinergic, and that tends to not help a lot with cognition. So, uh, I think it's probably going to vary from patient to patient, but generally speaking, I think it's helpful to categorize symptoms into positive, negative, and cognitive, and then see what's predominant, and then based on that make a decision. But if there are no residual positive symptoms and it's mostly negative and cognitive symptoms, not sure I would use clozapine. I don't think that would be the go-to drug I would use.
And that's why we have continued medical education, right?
Correct.
What about its anti-suicide effect? Can you speak to that?
Right. So that literature came in the 90s. So there were a couple of studies that were conducted in which clozapine was compared to uh, olanzapine, which structurally, from a chemical perspective, is a similar drug and has many of the side effects that clozapine has. So um, in that study, it appeared that people who were treated with clozapine, and these are not patients that were assigned to clozapine because they were treatment resistant. These were patients that had suicidality, uh, not necessarily in the context of treatment resistance, but clearly in the context of schizophrenia. These patients tended to do better in terms of suicidal ideation and other outcomes related to suicidality compared with patients that were treated with olanzapine. So that's why um, there was that was part of the most robust data that came regarding its anti-suicidal effects. And it's very relevant because the mortality of people that live with schizophrenia is premature by about 15 years compared to the general population. So that is something that I don't think we pay enough attention to. Our patients die much earlier than those who don't have the illness. And when you look at the drivers, it's a very complex situation, and there are many factors that contribute to that excess in premature mortality. But certainly, suicide is one of them, particularly earlier on in the course of illness. That's when patients are most vulnerable to dying by suicide. Um, so that's it's very that's a certainly an outcome that's very important to prevent. And as I said, I mean, clozapine has several pieces of data that are quite robust in the direction of anti-suicidal effects.
Yeah, I mean, I can't agree with you more that, suicide is something that if we don't impact early in treatment, then there may not be any treatment to be had after that. I'm a big proponent of lithium treatment, even in low doses as an anti suicide measure. In listening to Dr. Kane on David Pewter's psychiatry and psychotherapy podcast, I actually started to recognize a lot of similarities between lithium and clozapine, the aforementioned anti-suicide effect, but also this fear of its use by patients and providers due to what I would consider to be a somewhat over exaggerated side effect profile, or maybe better said, a lack of respect for the benefit to risk ratio. But the way that Dr. Kane talked about two other aspects of clozapine, one being the idea of clozapine super responders, which I've similarly witnessed with lithium firsthand with a robust and sustained response within a couple of weeks, but also with how he uh, spoke about talking to patients, stating that they need to commit to the medication for 3 or 4 months before dismissing it as ineffective. Something that I also tell my patients when we're trying to decide whether or not to start something like lithium. He alluded to the effect building far beyond 3 or 4 months, similar to evidence that lithium's effects may not max out until about 2 years. What do you make? I got several questions here. Answer them as you please. But what do you make of the similarities between the two? Do you utilize lithium or even low dose lithium regularly in your treatment of schizophrenia? And do you think that lower doses of clozapine over longer durations of time can provide similar benefit while minimizing risk?
Oh yeah, so there's a lot of questions. I'm not sure I will address all of them, but feel free to follow up with anything I left unanswered. So regarding the similarities of clozapine and lithium, I think that to me one of the first similarities is the fact that these are highly underutilized treatments. So these are treatments that have proven to be very effective, but that are used much less than what you would expect by any metric. So I think that this begins with the insufficient training that we have in using these drugs, and we know that the way you practice during residency is it's going to be very influential towards the way you practice for the rest of your career. If no one teaches you how to start someone on clozapine, if no one teaches you how to start someone on lithium, you're not going to start doing that after your training. And I think it's a very to me it's a big problem, and I think it's a missed opportunity that this is not taken more seriously by some of the organizations that supervise the medical education. But to me, the fact that people graduate without having started the patient in either of these drugs, which happens all the time, I think it's very bad, and sets a very bad precedent, because you know most of these trainees are not going to start doing this after their training concludes. So to me that's very very unfortunate, and I wish that there was a more systematic effort to make sure that when residents graduate, they feel comfortable with using these treatments, because there are other drugs or other interventions for which they're going to have CME. They're going to learn how to use drugs that come in the pipeline, which we need. It's not, I mean, obviously we need those drugs, but the drugs that don't have that sponsorship fall orphan, if that makes any sense. So you know to me that's one of the sad similarities. Also, that something that comes with that is how they are presented to patients. I think that we don't do a very good job presenting these interventions to patients. When you tell someone that I'm going to give you this drug that may kill you, patients are going to say no thank you. Or when you tell someone, I'm going to give you this drug, but it may kill your kidneys, and you're going to have to do regular blood work to make sure that the level is all right, they're going to say no thank you. I think that, but that's a very unfair representation of what these drugs are. I don't think that we train people. I don't think we evaluate people based on their ability to provide uh, and a proper explanation of why we think that this medications is what we should use for them. So, so to me, that those are sad similarities. And then more from the clinical perspective, the fact that they are both drugs that have shown to gain effectiveness over time. I am not sure. I think that I'm not sure if why would that be. I mean, I could hypothesize that if something works, over time your life is you're going to accumulate some of those benefits over time, right? So if you're able to have your psychosis under control, you may be able to improve some social relationships, go back to work, etc., which is going to have a positive effect. Same same thing might be said for lithium. So that could be a reason why they seem to work to keep working overtime. Um, and then regarding the low dose, I don't think that the data for augmentation of lithium, for instance, in treatment resistance, we some people like to use lithium for whenever you're using clozapine and there's a low white blood cell count, that may help to get those white cells, the count of white cells up. But I don't think that there are great data suggesting that increases the effectiveness of lithium. So I that's not something I would encourage generally. Um, and low dose clozapine, I think it's not. I think that I would recommend using the dose of clozapine that proves to be effective. I wouldn't use a low dose because that may uh, increase the risk of people developing agranulocytosis without getting the full benefit of the drug. So I think that's not a way to maximize the risk benefit ratio. So I would recommend the dose that is effective, the minimum dose that's effective addressing symptoms.
Is there any pharmacologic overlap that you know of that may provide any explanation of the anti-suicide effect?
Not really. From a more neurobiological perspective, I don't have any insight into whether there's a shared mechanism. Um, so I don't really know. I mean, I don't think that we really understand the mechanism of action of anti-suicidal effects in general. So I'm not sure. That's certainly an area that we need to understand much better.
Yeah, and I maybe take it a step further in that I fear that there may be a concerted effort against training somebody like me to use clozapine and lithium because, as we've already stated, they're so cheap. They could keep people out of the hospital, and while that certainly saves the society as a whole money, it does not save the hospital money if they don't fill their beds and they don't have their regular turnover of admissions. I just have some skepticism about that because I really do think if researchers and scientists drove what was actually effective, that we would see a lot more use of lithium. We'd see a lot more use of clozapine. Um, but again, these are questions that I don't
I
have the obvious answer to.
I
Um,
I, I disagree a little bit with that because I think it's more the fact that there are many agendas that and I don't mean this in a bad way, but like there are different organizations that want to push for whatever they're working on. That thing that does not exist for clozapine or injectables, or well, maybe for injectables a little bit, but even there, I mean, there are many companies that are developing injectables, and it's hard to get people to use them, and we know that they work very well. And same thing for lithium, right? But even when there's an incentive for from companies to have a greater use of these drugs, you see that there's not an overutilization of long-acting injectables. I mean, LAIs are grossly underutilized, same as clozapine. So I think it's more that it's a very complex um, scenario of forces that are pushing and pulling in different directions. This requires a major change in the system because you need to train people differently. You need to it's not like, okay, you need to prescribe more drug A. It's really, you have to practice differently, and that's a huge undertaking. I don't think anyone is prioritizing that over other stuff, and as a result, you know um, there's less use of this different drugs. So I don't think it's a concerted effort. I think it's more like that. Unfortunately, it requires a lot of work, and I don't think anyone is really pushing for it. Unfortunately.
Yeah, and you're absolutely right. I mean, this is a multifactorial issue. I mean, there is the patient perspective of patients and myself included in that. I mean, we want quick fixes. We want to go see the doctor. We want to take something that makes us feel different, which is why I think it's so important. Dr. Kane talking to his patients about, look, you've got to suspend your disbelief and commit to the process of taking this medicine for 3 or 4 months, and then we will start to evaluate its effects. I think there's certainly a major component of our training, and if you do not have um, people who are training you that teach you how to utilize certain medications, you may never learn how to utilize them. And then you come out of training and you're not comfortable with utilizing them. But I also think that there is just, way too much um, manipulation of the research system by industry and too much overlap with the regulatory agencies and the entities conducting research and how I receive my medical education and what books and what guidelines I am exposed to. But you're absolutely right. I mean, there are so many different factors to this, and I do want to point out that I don't think that big pharma is this horrible entity. I mean, they allow for innovation and they fund a lot of research, and there's certainly a lot of good, conscientious pharmaceutical companies, but there's certainly evidence of less conscientious and companies that are utilizing the system to their financial benefit. So, but it's certainly not everybody, and there's a lot of different factors and entities that bear a little bit of responsibility there. um, I could talk about that all day, but not why I had you on. And so tell me what barriers are stopping more providers from using clozapine. I know we have the REMS program, which is meant to help to mitigate the risk of using drugs that have potentially severe or serious side effects. And clozapine does warrant some fear in terms of trainees recognizing that it has potential fatal cardiac issues like cardiomyopathy, enlargement of the heart muscle, immune system side effects, agranulocytosis or neutropenia, essentially making the patient more susceptible to opportunistic infections like we may see in HIV progress to AIDS, but also nuisance and annoying side effects like excessive salivation, drowsiness, sleepiness, and constipation, which could be annoying or it could be serious if it progresses to a paralytic ileus or a bowel obstruction. How do you evaluate the benefit to risk ratio of this drug? And is the fear about clozapine warranted or is it maybe over exaggerated?
Well, to me, the point to start uh, would be to evaluate this in relative terms, not in absolute terms. And what I mean by that is that you have to evaluate what are the risks of bad things happening, bad outcomes if I use clozapine, but also what is the risk of those bad outcomes happening or other bad outcomes happening when if I decide to not use clozapine. Okay, because that's a real choice. Like, do you use clozapine, yes or no? We know that people that don't use clozapine and have treatment resistance, they tend to do worse as a population. Okay. Unfortunately, the biomarkers are not developed to the point that we are able to tell a given person whether they're going to respond or not, or whether they're going to develop a particular side effect or not. But from the population level, if patients who are not using clozapine tend to live less, and they tend to have more morbidity, more medical illness, and they tend to have a shorter lifespan. And so then if you use clozapine, there's no guarantee it's going to help. Actually, in fact, most patients may not respond. Okay, so we have to be very upfront about what are the chances of uh, of seeing a response with clozapine. But certainly the chances of response are way greater than with any other drug. And then the potential side effects could be the annoying but common side effects, as you mentioned. Those are actually quite prevalent. So there's a high chance that some of them are going to be experienced. And those are things, as you mentioned, like sedation, salivation, constipation, which are generally manageable. I think that the data suggests that that's not a reason why people would stop clozapine. So it means that for those people, even when they are experiencing them, it's worth because they are experiencing some improvement in symptoms. There are also the more serious side effects like agranulocytosis, myocarditis. These are side effects that we monitor carefully for and that are very rare. So, in general terms, I think that, again, at the population level, uh, there are there's also a lot of risk of bad outcomes if you have treatment-resistant schizophrenia and are not using clozapine, which should be something that should be considered. And the risk of dying from agranulocytosis is like 1 in 3,800. So it's a very small risk. The chances of experiencing clinical response are about 40%, when other treatments have been used and failed. So I think that, again, in general terms, it's obviously a decision that has to be taken case by case. But in general terms, I think that the risky outcomes don't justify to not use it, to not give it a chance. If you try it, it doesn't work, okay, then you have to decide what to do next. But to me, the first question is, you should try it. Hopefully, over time, we'll be able to develop biomarkers that tell us whether someone is likely to respond or not. And then we'll have to see what can be done for people who are at low risk of response. But we are not there yet. I think that now the only way of knowing is by giving it a try.
Wouldn't it be great if there was a database available that was maybe monitored by expert mathematician and involved providers and researchers that could put an actual number on the risk of these things and put an actual number on the benefit, plug all of that into an equation and be able to spit out a essentially a benefit to risk ratio, because like you're saying, I mean, the risk of agranulocytosis is very low. And if you compare that with the risk of a positive outcome, even after two failed trials of other antipsychotics, then being able to present that to the patient comparatively against other drugs would probably make it a little bit easier to convince patients to utilize. Or do you know of anything like that? It's like a pipe dream in my
we,
mind, but
we are we are actually getting started in a project, an NIH funded project that is doing a little bit of that. So what that is doing is that's using neuroimaging to calculate the chances of treatment response to a first line antipsychotic in early phase patients. And if you're predicted to be a non-responder to a first line, then the question is, are you at risk of agranulocytosis? I'm sorry, are you at risk of weight gain? So there are some genetic biomarkers that can be used to that effect. And and then if you are at low risk of responding to a first line and also don't have the genetic background that makes you vulnerable to weight gain on clozapine, then we're going to see whether clozapine is a good first choice for you as opposed to a traditional antipsychotic. So we are running that research in which the treatment decisions would be based on these biomarkers, and that's something we're going to start soon. So I mean, we are very glad that we'll be able to develop that project in the next few years.
yeah, absolutely. That sounds incredible. I wish we had that for all of our treatments across the board, where we could put a factor next to the side effect, which agranulocytosis, the factor would be a high number, but for something like excessive salivation, maybe that factor wouldn't be nearly as high as the potentially fatal one. Um, Now, you've also done a lot of work on other key developments in our understanding of effective ways of improving outcomes in schizophrenia, which I really appreciate because you focus on outcomes. And regardless of what the theory is behind it, I want to know where I can find good outcomes for my patients. I was reading your paper earlier on the pharmacologic treatment of schizophrenia. How far have we come? I think from 2022. Tell me a little bit more about that. How far have we come?
Well, I think that I mean, if you look at the history of psychopharmacology of schizophrenia, starting with the development of chlorpromazine, yes, we've developed uh, a number of drugs. I think that there have been some highlights that we made on that paper from the perspective of pharmacology. I think that we, I mean, seems very basic, but we are starting to understand that taking meds every day is not a good way of treating someone that has a chronic illness. Seems very basic,
You
but I
can't
think that
say
we are
that. You can't say we're not supposed to take meds every single day. This is America, right? We're supposed
well.
to take meds,
So
multiple meds every day. I'm being
right,
sarcastic,
so
of course, but
so right, so I think that we are understanding. I mean, it's part. So the whole thing about long-acting injectables has been very interesting because they were highly, or they were used at a much higher rate before second generations came around. And then second generation antipsychotics came to the market, and long acting injectables were not being used anymore. And I think that that's unfortunate because it's these are also grossly underutilized interventions that help people stay relapse free. And not just that, but also help us understand if someone has resistance or pseudo resistance. Sometimes people may be experiencing some symptoms, and it's just that they don't have the appropriate plasma level continuously, which is what a long acting injectable delivers. So, I think that we are understanding that better, and we are underusing long acting injectables, but I think that over time I think that that's getting better. So to me, that's an improvement. I would also say that there are new mechanism of actions that are being explored that are promising. So one of them is muscarinic agents. And full disclosure, as I said before, I consulted a couple of times for a company that develops these drugs. But I think that these are very interesting drugs. The mechanism of action is rather old. I mean, it was something that was investigated, I believe, in the decade of the 70s, and really was not used until recently for various reasons. But I think that the data are very interesting. So I think that that's a major development. We will see what that looks like in terms of the treatment that we provide to patients in the next decade. But I think that's interesting. Um, I think that other developments is the understanding that it's not just using one drug, that you have to treat a whole ecosystem with each patient, right? So I think that to the incorporation of coordinated specialty care into the first line of treatment for early phase patients also seems very obvious, but has only been done in the last few years, right? So understanding that yes, you have to do evidence-based psychopharmacology, but also you have to treat the patient in their context. So you have to work with the family, you have to work with supported education and employment. You have to target not for symptom control, but more for recovery. So these are also things that seem obvious, but I think that it's only recently that they are becoming more basic and more kind of like a common understanding. Yeah, so these are some. I think that there's been important progress. Now I think that with the development of uh, biomarkers, that's an area in which I am working. I think it's very exciting, so that we can bring the biology to change outcomes and to inform specific decisions. I hope that that's um, the next frontier.
Um, is one of those drugs in the pipeline promoting increased acetylcholine? Did I see that?
So the way muscarinic agents work, and there are many of them in the pipeline. There are many companies that are investigating different versions of this drugs. But essentially, the way they work is by modulating dopamine, not directly on the D2 receptor, but upstream. And it addresses two of the major mechanisms that we know occur in the pathophysiology of schizophrenia. One of them is at a cortical level. We know that there is dysfunction of NMDA receptors, and that leads to some what's known as the excitatory inhibitory imbalance in those microcircuits, which may lead to cognitive symptoms. So by working by intervening on cholinergic on muscarinic receptors, the EI, the excitatory inhibitory imbalance, could be partially addressed. So that's one potential mechanism of action, and that might explain the pro-cognitive effect of these drugs. But also that restoration of EI imbalance downstream may help to reduce the dopaminergic firing of neurons into the striatum. Then some of these other drugs have other also calling a muscarinic effect in the midbrain, which again reduces the activity of these neurons that fire from the nigra, from the substantia nigra, and the ventral tegmental area into the striatum, which may be driving some of these positive symptoms. So, I think that so these are the two major hypothesized mechanisms by which these drugs would work.
Yeah, and it's striking to me because I think if we can be curious about what and why our patients do what they do, we can learn a little bit more about the illness. And the classic example of that is the high rates of tobacco use in schizophrenia. I think it's easy to ostracize people or demonize them for their tobacco use, which is, can be kind of taboo. But I think it's much more from a curious perspective to say, well, why does this population use nicotine, which is, affects some of those same symptoms and systems that you're talking about. Um, so, one other kind of line of questioning before we wrap up here. So, as I was saying earlier, I typically find myself somewhere in the middle of most academic, political, social issue discussions. For example, I think it should be the exception to the rule to take a patient's rights away and force treatment. But I also see the need for it in patients with anosognosia or complete lack of insight, who are influenced by severe paranoia or psychosis. And I've seen people improve in their symptoms and also be more willing to receive psychological and social services in their medicated state, allowing them to engage in treatment that may not have been possible without the use of forced treatment. Obviously, with every patient, we want to try to meet them where they're at, involve their families, their communities in their treatment as much as possible. But sometimes that, frankly, is just too idealistic and not very realistic. What is your stance on involuntary hospitalization and forced treatment in this population?
I mean, I think I agree with you in the sense that I mean, anyone who has worked as a psychiatrist understands that there are always going to be situations in which there's no alternative. I mean, there are some situations in which uh, people are at risk of hurting themselves or themselves or others. We see this every day at the hospital. So I think that there's really no other way so that they are safe. Then there's obviously some degree of interpretation as of at what point should you take away the rights of someone to make a decision. I think I mean, I'm not sure how it works in other states. Here in New York, it's either the danger to self, others, or the inability to care for self. There are other states in which that third component is not included. It's a political discussion. I mean, my my perspective on this is that based on my experience and what we know from the research, perspectives the perspective for many people, their perspective on their illness evolves over time, and especially at the early phases of illness, that's when there's greater rates of treatment discontinuation. And to me, that's related to the fact that you have to accept that now you have a chronic illness for which there's a lot of stigma, and that's very hard. That may really change your life, and that's very hard to take. That's very hard to understand, and not everybody has the same degree of support and understanding. And I think that that changes over time, and over time you may realize that some of this could be beneficial, some of these treatments could be beneficial, and some of these drugs which are very nasty. I mean, I have not heard anyone tell me I love this antipsychotic, because these drugs are very unpleasant to take. So at some point people understand that people are living with in this situation, they understand that this drug sucks, but there's some positive that comes with it. So the problem is that so the problem is that if you realize of that too late, there's maybe not so much that you can do, right? So if you have had a number of relapses, you've already had problems with your social network, with your ability to stay in a job. you know if you realize after damaging all of that, then that's of no good use, right? So okay, um, to me that's very unfortunate. So that's why I tend to be I don't know if you want to call it paternalistic, but I think that we should try to help people stay, not get to that position, so that if they realize and they change their mind, and they start seeing some benefit to treatment, they still have some opportunity to to get back on track. So I think that it can be, I mean, my perspective is that I err on the side of protecting someone rather than letting them make a decision if I think that it's going to be um, not beneficial, or dangerous, rather not dangerous to self
And
or
I know
others.
that you've done a lot of work with early intervention services for first episode psychosis. I think it's pretty generally accepted in psychiatry that the more untreated episodes, or the longer the untreated symptoms, the worse the outcomes and the more resistance to pharmacologic treatment exists. Um, but I asked that because again, it's a situation where I do believe that we should try to avoid involuntary treatment as much as possible. But I think when you've worked in enough psychiatric units, inpatient, state hospitals, that you recognize that some people really do or can benefit um, from some form of forced treatment, even though it's not ideal. Ideally, we would have everybody be completely involved in agreeable to every treatment, but it just doesn't happen in this population all the time, and people may be damaging their brains potentially beyond repair without early and kind of, I don't want to say aggressive treatment, but early treatment, and kind of getting that started and trying to find the right pharmacologic aid along with social and psychological services. Um, yeah. Anything else to add there?
No, to me that's the question. I mean, to me the ethical dilemma is: do you become more paternalistic when you know that this can change over time, and maybe a few years from now that person may change their perception on treatment, and but it might be too late for them to to address some of the problems that emerge with illness, like the damage to social network and employment, their ability to stay employed, etc. So to me that's the ethical
Yeah.
question.
Well, thank you so much for answering these questions, educating myself, my listeners on treatment resistant schizophrenia and the importance of using clozapine. Um, is there anything else that you would like to add that you have been working on or are passionate about, to throw in here before we wrap up our discussion?
Well, I mean, if so, to your listeners, if some of them are living with schizophrenia and have, and they think that they may have treatment resistance, I would strongly urge them to not normalize some of the symptoms. So don't normalize the fact that you're experiencing some delusions, some hallucinations, disorganized thought, or behavior. I think that's important to make sure that you've done everything that should be done to confirm that those symptoms are truly resistant. So, I would encourage them to talk to their doctors about the use of clozapine or long-acting injectables whenever it's appropriate. And to doctors, I would tell them that you know I think that patients may really have their lives changed by clozapine. I mean, we've all seen clozapine super responders. Not everybody's going to be a clozapine super responder, but certainly for some people, it's really a life changing intervention. So I think it's important to make sure that we optimize the use of this drug. And there are always questions that come with it if you haven't been using this drug lately or prescribing this drug, but there are many resources. I think SMI Advisor, it's sponsored by the APA, and I think or SAMHSA, and I think it's a great resource. But there's a lot of stuff that you can get that we can all get as a community to feel more comfortable prescribing this drug.
Is there anything more rewarding clinically than to see somebody have a super response to clozapine?
I mean, I remember I remember the people that I treated when I was in residency, and I remember some of this clozapine miracles. So yeah, I mean, that stayed in my mind. And I graduated a few years ago, but I still
Yeah,
remember.
I had a woman who I put on lithium 150 milligrams for suicidality. Didn't even come up in our discussion. Her husband had to drive her to her appointment. She was afraid of, um, driving off the road or something on the way there, and had active suicidality. And she came back a month and a half later and told me that she had had a week every month of her life since the time that she went through puberty and started having regular menstrual cycles, where she would be extremely suicidal. She described herself as an emotional wreck, a lot of crying episodes. And she said, and I didn't have that at all um, in my last period. And then several months later, still, and has not had any PMS, PMDD symptoms. And honestly, I haven't really seen her a whole lot lately, and that's very rewarding to me.
That's
But
good.
those super responses
Yeah.
are it. I haven't seen them with other drugs typically, or if I have, they haven't stayed over the through the course of time. Last thing to add, and I should have asked this earlier, but uh, keep me up to date on what is the most recent kind of. I know there was something going on with the REMS program and trying to take away that requirement for clozapine, and hopefully, without putting any patients at risk, being able to limit the very tedious lab work with a weekly complete blood count.
Well,
What's the latest on the kind of recommendations with labs and trying to make it more
well,
reasonable for patients to be on clozapine?
all I know is that the FDA is thinking about how to redo REMS. I don't know that they are discussing about getting rid of it, but I think that they are reconsidering. I think that they're accepting the fact that the current situation is really unsustainable because it doesn't really work. So REMS is currently not enforced, in part because it's so difficult to do that it may threaten some patients may not be able to get their medication because it's so cumbersome to do. So so that's why it's not being enforced, but that's not sustainable because then it defeats the purpose. So I hope that what the FDA is thinking about is how to implement a model that is able uh, to be implemented, that can be scaled in a way that's not too cumbersome for prescribers, but at the same time, make sure that people are not getting clozapine when they should not be getting it. So that's all I know.
Yeah, and that is a very, very cumbersome. I think it prevented several patients from having an appropriate clozapine trial when I was in residency, simply because there's a lot of monitoring that had to go on with it. And I mean, on a very realistic level, I do think that some providers will choose the less restrictive option at the expense of what may be more beneficial to the treatment. Again, similarly to lithium, which should absolutely be the gold standard in bipolar disorder. And I would argue that that goes beyond just bipolar into, using low doses in schizophrenia and using low doses for suicidality and unipolar, or what we now call major depressive disorder. But well, hey, I've really enjoyed talking to you, and I think that you definitely have a very good head on your shoulders, and understand things in a definitely about schizophrenia and clozapine at a level up here compared to myself, and probably a lot of younger psychiatrists who don't have as much experience with it. But thank you so much for coming on, and yeah, if there's ever anything else that comes down the pipeline, or that you want to talk about, certainly just let me know, and we'll bring you back on.
Certainly, thank you so much for the invitation, and I hope that this was of interest to the audience.
Absolutely. Thanks again for watching and/or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.